Parkinson's disease is a progressive disorder that affects the nervous system and the parts of the body controlled by the nerves. Although Parkinson's can't be cured, medicines might significantly improve symptoms. Understanding Parkinson's, tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be discussing Parkinson's disease and taking viewer questions. Parkinson's disease is a neurodegenerative disorder that primarily affects movement. Common symptoms include tremors, stiffness, and difficulty with balance and coordination. Parkinson's is a progressive disease, meaning symptoms worsen over time, leading to significant disability in some cases. There's no cure for Parkinson's, but treatment options such as medication, physical therapy, and deep brain stimulation can help manage symptoms. Tonight, we will discuss Parkinson's and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio by Dr. Wijdan Rai from Sanford Neurology Clinic in Sioux Falls. Welcome, Dr. Rai. Thank you for joining us.
Very excited to be here.
Yeah, great. So tell us a little bit about yourself. What's your specialty, and how did you become interested in particularly the Parkinson's part of your specialty?
Yeah, so I went to medical school in Pakistan. Mm-hmm. It's called the Al Khan University. And then from when I graduated from there, I did my neurology residency at the Ohio State University. Mm-hmm. From there, you go into fellowship. Okay. And I did my fellowship at University of Pennsylvania in movement disorders. Mm-hmm. And so that is sort of what has led to my expertise in Parkinson's disease.
Yeah.
I really enjoy Parkinson's, seeing Parkinson's patients, because I really like seeing the same people over and over, kind of coaching them and helping them through a disease that can be very difficult as it's progressive and debilitating. So it's really meaningful to be able to help them through that.
Yeah. Great. You mentioned that your training is in movement disorders, which is broader than Parkinson's. What are some other movement disorders? Enlighten us about that.
The most common ones are Parkinson's disease, essential tremor, and dystonia. Okay. Dystonia can involve any part of the body, but most commonly the neck, so we call it cervical dystonia. And then you have a smattering of other diseases, such as Tourette syndrome, people who have hemifacial spasm, and other kinds of movements that can occur in conjunction with other diseases. So, for example, you can have movement disorders with a stroke, you can have movement disorders with MS, so it can be part of a larger other syndrome as well.
Got it. Well, let's talk about Parkinson's disease. I think a lot of people have a picture of what a case of maybe severe Parkinson's disease looks like. What defines Parkinson's disease? How do we know that a patient has it?
So the hallmark feature of Parkinson's disease is bradykinesia, which is a fancy way of saying slow movements. So slowing down is really the main feature of Parkinson's. So when you see people and they're saying that they are walking slower, they're moving slower, it's taking them longer to do things, that slowness is really what the feature of Parkinson's disease that makes that diagnosis. So you have to have that in order to get the diagnosis. But then you have other features as well. So you have tremor. That's probably the most well-known one.
Sure.
Because it can be very dramatic. The tremor really is a resting tremor, so it comes out when usually you're not paying too much attention to it, so when it's just sort of like hanging by your side while you're walking or sitting, or when you're talking to somebody and it's kind of going during conversation. So that is another sort of feature of it. And then you can have something called rigidity, which is increase in muscle tone. So when people have a way to sort of not able to move their arm very well, their muscles feel very tight, that's another feature of it. So you need to have 2 out of the 3, with bradykinesia being the main feature. Often people have all 3.
Sure. And how do we diagnose it? Like, is there a lab test or an imaging test, or how do we diagnose Parkinson's disease?
It is a clinical diagnosis.
Love that.
So yeah, what we mean by that is that it takes the history and the story, and you put that together and see what you're seeing on exam. We have gotten a lot better about that, actually. There is a test that has been available in more recent years called a DAT scan, D-A-T, dopamine transporter scan. So quick lesson, Parkinson's is a disease where your brain is not making enough dopamine. So what the scan does is essentially measure levels of dopamine in your brain. If you are not making enough, then you have Parkinson's. And if you're not, if you're making enough of it, then you do not have it. It's a very accurate test, about 95%.
Okay.
We do not do it in everybody.
Right.
If we get the diagnosis clinically, it's very clear. We don't have to put them through that test.
Got it.
There have been more targeted ways in which we can diagnose it as well. One of the proteins called alpha-synuclein that we find in Parkinson's can be detected in skin. So we actually have a skin test for it as well. And more recently, we are making it available in spinal fluid as well. Eventually, we hope that there will be a blood test.
Yeah. Are we fairly good and accurate at diagnosing Parkinson's without these tests clinically?
We
Maybe
are.
It varies depending on who we are.
Right,
I suspect you are very good at diagnosing Parkinson's.
I would hope so. Yeah, it really depends on who's diagnosing it. I think that does make a difference. From your primary care provider to a general neurologist to a movement disorder specialist, there is an increase in accuracy with the diagnosis. What we're really hoping for is also earlier diagnosis, right? So we want to be able to catch them early. We do know that the disease process for Parkinson's actually starts years, if not decades, before the symptoms ever become obvious. So
meaning
we are
like changes on the scan or in that dopamine level would be detectable before
the neurodegenerative process that you were talking about earlier can actually be detected in the brain for very many years before the bradykinesia and the tremors and the rigidity ever become obvious. So there's a few clinical signs. Anosmia or loss of smell is a big one. That kind of went out the window with COVID a little bit, but you have a lot of people who do lose that. And then when I ask them that question, they're like, how did you know that I've not been able to smell for 15 years?
Interesting.
And constipation is another, though that's very common. And something that's kind of unique called a REM sleep disorder, which is dream enactment behavior. So people who act out their dreams at night. If you have the three, you're all but guaranteed to develop Parkinson's later in life.
Got it. But those tend to happen before the movement symptoms. What do you find, when you're seeing a new patient being diagnosed with Parkinson's, what do you find that either the patient themselves or maybe their family member, what did they notice that made them come in and be curious about something's wrong? Like, what is it? Is it something about their movement? Is it something different?
Correct.
Yeah.
It is either they're slowing down a lot, or they're tremoring, or both.
Sure.
Those are the two most common reasons why people will refer to me and how I get to the diagnosis.
Yeah.
So they'll be like, we're walking down the street and they used to be able to keep up with me, now they can't. They're shuffling their feet. They're not picking them up very much and the sound is driving me crazy.
Yeah.
the sound of shuffling, or they're not swinging their arms very much when they're walking.
Yeah.
So something's different, they're hunched over more.
Right.
So that's the walking part. Falling more. The tremor is probably more obvious to other people than it is to the patient themselves. Their wife or husband or children will be like, I noticed at Christmas that they were really shaking, but they didn't seem to notice that they were doing it. So I'll get a lot of referrals after the holidays.
Yeah, got it. And then how about, does Parkinson's cause dementia in and of itself? And if so, like how often do those two things go together?
Yeah, so dementia is a bucket term. It basically means cognitive impairment, and you have very many reasons for dementia. Alzheimer's being sort of the most common and well-known. People can develop dementia with Parkinson's disease that is independent from the process of Alzheimer's. I do find that this confusion exists among patients. They seem to think that they will go on to develop Alzheimer's.
Oh, okay.
And I will say that is a different disease. You can develop dementia, but it's a different kind of dementia. They're not all of them are not guaranteed to get it. And it tends to be a late feature. It tends to be, 15 to 20 years into the disease. There might be some short-term problems. I forgot what I came into the room for kind of thing that happens more and more. But it never really people are really afraid of like, I will forget who this person is, or I'll forget how to take care of myself, which is what's really awful about something like Alzheimer's.
Yeah.
And that just doesn't really happen in Parkinson's to that degree.
Yeah, yeah. Good to know. And as far as you mentioned some other things that can go along it, like the sleep disorder. Are there other things that tend to happen commonly in patients with Parkinson's disease?
Yeah, so motor symptoms, which is what we've mostly been talking about, the slowness, the stiffness, the tremors, the walking. But then you also have non-motor symptoms. And so some of them I've alluded to, the loss of smell, the constipation, and the sleep disorders. Another really common one I come across is positional lightheadedness, which is a change in blood pressure as they change position. Typically, most people, when they stand up and their body has to work against gravity, their blood pressure will rise so that all that blood can get to the brain. Parkinson's, that's broken. It doesn't really happen that way. So instead of going up, it goes down. People can develop that head rush feeling when they stand up too fast, a lot. You can even pass out and fall and injure yourself because of it. So I feel like that's an under-recognized feature of Parkinson's as well. And then hallucinations is another one. They tend to be visual, and they kind of can start off with very mild ones, like I feel like somebody's in the room but no one's there, or see something out the corner of my eye but nothing's there. But then they can evolve in very interesting and very well-formed ways. You can see entire creatures like insects, even animals, and even children and people. What's kind of funny about it is that it doesn't end up being really all that bothersome to the person seeing the hallucination, but they'll point it out and everybody around them is a little freaked out. Like there's a cat at the end of this couch and you're going, there's no cat. So but visual hallucinations is another one that can happen.
Is that a later feature typically too?
Correct.
What's the most common sort of age group in which Parkinson's symptoms first present?
I would say late 50s to 60s is when most people will present. Anything that is before the age of 55 is considered early onset. And that is just not as common. And most people will present around that time. I will have mostly people in their early 60s to mid 60s that are coming, although I see a huge range as well there. But that's the most common.
And how about, does family history matter? Like if you have a parent who had Parkinson's, are you more likely to get the disease, or is that not a close association with this?
There's an interesting relationship between genetics and Parkinson's. We don't think of it as a genetic or hereditary disease. If one of your parents has it, you are not necessarily doomed to get it. The early onset ones where might be a little different. You can have a lot of genetic predispositions there. So if somebody tells me that they have a parent who developed Parkinson's in their 40s, you maybe have a higher chance, and we do have genetic panels for tests to that kind of thing. But vast majority of the time, it's what we call idiopathic, meaning that it happens for no discernible reason. We will see people who have multiple family members with Parkinson's, and I get asked that question a lot, that, I have so many people in my family with Parkinson's, and then I developed it as well. Won't my kids develop it? And I have to tell them that it probably is not your genetics, but your environment in some way. But there's no good way to prove that. We do think that there is a strong association between toxins and Parkinson's disease, something that you were exposed to at some point in your life, or multiple points in your life, or constantly. It's hard to quantify these things. But essentially, the family is being exposed to all of the same things. So, for example,
are there particular toxins that have
insecticides, pesticides that a lot of farmers around here, so that's why Parkinson's is more common in rural farming communities. And so when they use a lot of those chemicals, they eat the food, they leaches into the water, they drink out of the well water. And if all of you are growing up and eating and drinking out of that same place, then it can look like it's a familial disease, when really it's that you all had the same exposures. It's very hard for me to know in any one individual, though, like why they developed it. And I get those questions, and I often say, maybe. I can't test for it. I can't prove it.
It's a relatively common disease in that age group of patients, too. I mean, I'm not a movement disorder specialist, and I feel like I have quite a large number of patients who have this disease.
And it's a disease that's present all over the world.
Right.
So you really can't say there's any one cause to develop it, because everybody will have different genetics and environmental exposures.
Sure.
But yeah, something is triggering it for sure. We just don't think it's one thing.
Yeah. Interesting. And so we'll talk a little bit more about, things that have evolved with treatments. There are some treatments that have been around for a long time and some that are newer. So I think we'll get through that piece by piece as we go through the show. I think we'll go to our first roll-in though. Linda Tyler is a speech language pathologist for Sanford Health in Sioux Falls. She shares how speech therapy is essential for people who have Parkinson's disease.
There's a few aspects with Parkinson's. They feel that becomes an issue with their sensory feedback, so they will end up talking soft, and then people will have difficulty understanding them because their voice is so soft. But the individual with Parkinson's really does not identify and are aware that they're talking soft. So the speech part comes in to help them bring their voice and their speech louder so people can understand them.
Individuals affected by this disease also have trouble swallowing, a skill that Tyler coaches them through.
If they would notice any difficulties with swallowing, if they're coughing or clearing their throat when they're eating or drinking frequently, those would all be reasons that they might be referred to speech therapy.
Speech therapy looks different for each individual and depends on the progression of the disease.
So we feel the sooner you start, the better, because then that also involves, when you're done with therapy, like home exercise program. So we feel that if maybe we start sooner, we can help you maintain a stronger, louder voice for a longer period of time, rather than waiting to come in for therapy after your voice and speech has become quite soft.
To strengthen a patient's vocals,
just drop your jaw, keep your neck relaxed, and bring it out nice and loud for me.
Tyler focuses on training their diaphragm.
So yes, with like a vocal strengthening, we're working on the diaphragm, and we want their vocal cords to become stronger, and we want to work on them being louder with their voice, or with the other program, speaking with intent. Frequently we'll have them do some loud ahs, where they're ah, with good support. But we have to also make sure that they're doing them correctly, that they have the good breath support.
Thanks for that. So therapy can be a big part of treatment and coaching with patients with Parkinson's disease. I guess, so we heard from speech therapy. So what are some of the common things that you see patients struggling with that a speech therapist can help them with?
Linda already mentioned one of the bigger ones, which is the loss of the voice. In both in volume, projection. It can become very hoarse. It can become kind of mumbly. Very difficult for people to understand. So that's a big one. We call that hypophonia. And speech therapists can really help with that. Just like any other muscle, the vocal cords need to be exercised. And so there's some very helpful but potentially silly exercises where they have to yell and scream and sing, but it really does help a lot with that. Another thing that a speech therapist can help with is swallowing problems, which can also develop in Parkinson's disease. So they help us make sure that we are keeping them safe, that things aren't going down the wrong pipe, and that we can keep their nutritional status up too.
Yeah, great. And another aspect of that might be physical therapy. Obviously, there's a lot of things to do with the muscles and movements. What in a physical therapy program, if you're referring people for Parkinson's, what do you expect the therapist to be working on that patient with?
A physical therapist will work on more big picture, larger movements. So I find that they work a lot on walking. That's a big one. They will, kind of teach the patient to be a little bit more mindful about how they're walking, because they'll be doing things that they don't even notice that they're doing. Standing up straighter and actually being conscious about swinging their arms when they walk, taking bigger steps, landing on their heels, because what they'll ultimately start doing is hunching, no arm swing, short steps, and landing on their toes. So it's kind of the opposite. It's kind of treating them how to do all of that. These are things that you and I don't think about.
Right.
Right.
And they don't just look different. They put people at risk of falling, right? Like those are
100%.
things that make your balance worse.
Absolutely.
Yeah.
All of these things that I just mentioned tell your brain where you are in space. And you kind of lose that when your movements become so small and difficult for your brain to kind of know. So a lot of physical therapy is teaching that. What I find that they help with a lot are home exercise programs, teaching patients how to develop a system that they will be consistent and regular with that is safe for them to do. I find them absolutely incredible in helping patients do that. Not everybody's going to be good about doing it, but at least they can help set them up in a way that can be really, really helpful.
Yeah. I mean, do you have patients who have Parkinson's that you think that you don't want to do physical therapy? Should everyone with this disease do physical therapy? Yeah.
Absolutely, 100%. Safely, of course. There'll be limitations to what you can do, and that's fine, but it's my favorite script to write. They're great people to work with too. So I guess we talked about therapy. So that's not even a medication or really a medical treatment per se, but a big part of trying to help people function better with this disease. Let's talk a little bit about medications now. So we have medications that certainly help with symptoms. How do these medicines work? How do we take them? What do they help with and what do they not help with? I guess let's start with the basics. So what's the most common medicine that you prescribe for Parkinson's disease? It is dopamine replacement therapy, carbidopa, levodopa. Anybody who has Parkinson's or knows anybody with Parkinson's will be familiar with this medication. It is our gold standard medication, best bang for your buck, initial treatment. As I sort of alluded to earlier, Parkinson's is a disease where your brain isn't making enough dopamine. So this is what this is. It's replacing it. It's not making your brain make more dopamine. It's replacing what your brain is kind of losing. So that is our most effective treatment, and it would also be the more effective for the longest and have the best sort of side effect and tolerance profile across their disease. So that will be the most common one that I prescribe.
And this, I find this an interesting medication because, usually when we're prescribing medications, there's very standard dosing that we use. This is very much individualized, right? Like you want to know from your patients, how long is this taking to run out? I mean, how do you titrate that to your individual patients?
Well, what I tell them is that this is always going to be a dynamic process. Like it's always going to be changing, and a dose that worked for you at one time may not work for you later. And a lot of people seem to think it's because they're developing a tolerance to the medication, that the medicine is sort of losing effect. But what's actually happening is that your brain is just losing more dopamine. Over time you're losing more, stands to reason I got to give you more. So there's no good way for me to measure that. How much dopamine have you lost? Oh, you've lost 30% of your dopamine, so replace 30% of your dopamine. That isn't really how that works. It takes a little bit of trial and error. So that's one way in why it's such a thing about why you have to dose it so frequently and why the dosing changes so often. Another is dopamine does not like to hang around in our body for very long. The body likes to get rid of it very quickly. And so that is what happens with this medication too, is that you take it and then your body just degrades it. And so that's why the dosing interval gets shorter and shorter and shorter over time as well. So you might get away with doing every 6 to 8 hours at the beginning of your disease, but then I'm having to go shorter and shorter, 4 to 6, even sometimes 2 and 3, and even sometimes every hour, which is very difficult, obviously. And so there's ways to manage that a little bit, but it's always something that keeps me on my toes. And that's how I ask patients is one, at your best, when you feel like the medication is working, how much better do you think you feel? And what proportion of your day are you spending in that state? And do you feel like that you get in between your doses okay? Do you feel like that by the time you take your next dose, you're not really noticing it, or are you kind of starving for it by the time it comes around? Like you're really slow and shaky and stiff, and you're just waiting 2 or 3 hours before you have to take your next dose. Sign for me to change something if that kind of thing happens. So that's sort of my basic way in which I figure that out.
But it is a challenge. I mean, patients have to take
absolutely.
high frequency of meds sometimes with this disease, but it definitely helps. What symptoms does the carbidopa levodopa help with, and what does it maybe not help so much with?
It helps with motor symptoms. The physical symptoms, things that are going to help you move. So the slowness, stiffness, tremor, walking is really what it's meant to help with. It does not really help with non-motor symptoms. So people will be like, oh, is this going to make my fatigue better? Is it going to make my sleep better? Is it going to make my memory better? It doesn't really do those things in a direct way. What I tell people though is, if you take this medicine and you find that you're moving easier, your brain is not fighting you. You're not fighting your body as much. You're not spending so much of your brain power just trying to make basic movements. You might find that those things are secondarily improved, but not as a direct result. So I would never adjust therapies or lead people to believe that it's going to fix all of their symptoms. And we do have separate treatments for those things, but that's really what we're looking for with dopamine therapy.
Yeah. Okay, great. Let's talk about other types of medications that you use then. So this is kind of the standby use for motor symptoms. What other stuff do you like? What other symptoms might drive you to prescribe different types of medications?
Yeah. There's other ways in which we can manipulate the dopamine system too. I'll say that there's medications that mimic dopamine. There's medications that help make it last longer or prevent it from breaking down. So there's medications that we can add as adjunct to help support the dopamine system that also ultimately help with the motor symptoms as well. When it comes to non-motor symptoms, it's a little bit more individualized, depending on kind of what you have. I mentioned the blood pressure problems that you have with Parkinson's. So we have medications to help raise the blood pressure, prevent that bottoming out when they change position. We have medications to treat hallucinations, so that they're not as bothersome or scary or, or bothersome to the family, whatever it might be. There's ways to treat that. Constipation, common symptom, absolutely can be treated as well. One of the kind of another lesser known symptoms is drooling. There's probably lots of reasons why that happens, but it can be very bothersome. It can affect their speech, their swallowing. It can be bothersome at night. There's lots of ways to treat that, including injections, Botox injections. So just really, there's a list of questions that we ask at every encounter, like, are you experiencing all of those things? And we'll just kind of figure out where each of these treatments will fit in there.
Yeah, so it's certainly not a disease in which, you might see how many hundreds of patients with this disease and everybody kind of has a different treatment plan.
Absolutely.
Depending on their symptoms. Great. And then, so medications, kind of wide array of things that you do beyond the dopamine replacement. And then talk to us a little bit, maybe we have some viewers who are familiar with devices that are used in Parkinson's disease, deep brain stimulation. Tell us about this. I guess let's go from the start. Like, what is a deep brain stimulator? It sounds kind of scary.
It's my passion. I'll say that.
And
it is a great therapy.
Yeah.
It can be really life-changing. It can improve quality of life. It is a device.
Yeah.
It is a battery pack with wires. And those wires are inserted into the brain. That's essentially what it is.
Yeah.
It's not a cure. Absolutely not. But just like our other therapies, it can really help with the motor symptoms of Parkinson's, often allowing us to reduce their medication burden, especially if they're not tolerating them or something like that. Then it can really be a wonderful adjunct to their treatment as well. The device is inserted surgically. We have to be very careful about the candidate selection for sure. Not everybody's going to be a candidate, but once we select the candidate, it is inserted surgically. The surgery is really just to put the device in. The fun and the treatment is what we do when we turn the device on later. And so that's what we do in the clinic. So we turn the device on, electricity runs through it, and then those tips of those wires are deep inside the brain, as the name implies, and you want those tips of those wires to be touching very specific structures. And when we electrically stimulate those structures, we see that there's very dramatic improvement in their motor symptoms. Very effective, 80 to 90% effective. And it's something that can just work in the background all the time, and not you have to take your medicine, you're wearing off, you're having side effect. It just kind of relieves you from a lot of that, for sure.
And so is that electrical stimulation mimicking dopamine stimulation that's missing, or is it a different sort of
We don't actually know how it works. We think that because of that loss of dopamine and dopaminergic neurons and the lack of communication that's happening between the neurons in those parts of the brain, we think we just kind of fix some of the neuronal dysfunction that's happening at that time. So we don't exactly know how it works. Historically, we actually used to, sounds insane, but we used to poke holes in different parts of the brain. This is we're talking 18th century.
Right.
When people were so disabled, like they used to shake so much that they just literally went to the doctor and said, just fix me, please. And the doctors would poke holes in the brain to see what happened. And so we figured out that there's certain parts of the brain where if you poked the hole, that your tremor would go away. Obviously not very precise, and there would be a lot of other complications. But those are what we call lesional surgeries. And then we realized over time, after trials in the 80s and 90s, that actually if you stimulate those same areas, you can achieve the same result without causing permanent damage to the brain. And so the first DBS device was FDA approved in 1997.
Okay.
So
it's been around a while.
Yeah, and so I don't want people to think that it's an experimental therapy. I don't want people to think it's a last resort. It is something that we fold into the therapy whenever appropriate.
Yeah. And you probably will take some medications as well, but it might reduce the amount of medicines you have to take to control your medication or to control your symptoms. So what type of patient is a good candidate for a DBS? Like, what prompts you to start having that conversation with your patients?
We have a general rule of thumb that about 5 years from symptom onset is kind of when you want to start talking about it. We don't want to do it too early. Parkinson's can sometimes evolve in different ways, and so we want to kind of give it a little bit of time to make sure that things are evolving as we expect. So 5 years is a general rule of thumb, and then the window to get Parkinson's is a large one, but a variable one. But there is a window. There is a point where it becomes a little too late to get it. I mean, it's a 10 to 15 year window. But at some point in time when some of the other late features of Parkinson's start to set in, like the dementia, not the best idea to put you through brain surgery. In general, the younger, the healthier you are, the better you're going to do with the surgery. But there's no like magical point where I'll be like, I can't do this anymore. But it's going to be different for everybody. We've done, people as old as 89 years old. So it's not like a hard and fast rule in that way. But you do want to have response to dopamine therapy, however. So that's a big one. So if you're somebody who's like, I've tried all the medicines and they don't work, you're probably not the best candidate for DBS. So it's not like it'll be like this will be instead of that because that didn't work. So you need to document that there's dopaminergic response. Tremor is, however, the one exception to this. Tremor can be really stubborn. It'll respond a lot of times to the medication, but sometimes it just really doesn't. And that is the one exception to that rule, that it may not respond to medication, but still respond really beautifully to the DBS. Okay, so if the tremor is really problematic, and correct me if I'm wrong, you might actually use DBS for other types of tremor too, right? Parkinson's is not the only disease that you use this for. Correct. It's approved for 3 different syndromes: Parkinson's disease, essential tremor, and also cervical dystonia, like I was mentioning earlier.
Got it. So do you use different places in the brain when you're treating those different diseases, just
different
based
targets
on their sort of mechanism?
There's actually 2 targets in Parkinson's, and 1 in essential tremor and 1 in dystonia. So with Parkinson's, we actually have a little bit of a choice about which one we want to go for, and there's different reasons why we would pick one over the other.
Got it. And backing up, because you've mentioned essential tremor a couple of times. So tremor being a hallmark feature of Parkinson's disease, but not all tremor is Parkinson's disease. I think I get that a lot in my clinic. Someone's noticing a tremor, they're really worried about Parkinson's disease. What features are different in a Parkinson's tremor and the essential tremor, which would be the other most common one that we see?
So essential tremor is really just a tremor. I think that's one of the biggest differentiations between the 2 diseases. Parkinson's becomes all these other things. You've got walking problems, thinking problems, all the other things that we've already mentioned. But essential tremor is really just a tremor. It's actually got a much more stronger genetic component than Parkinson's disease. It tends to run in families. So that is more like, if a lot of people in your family have it, then you probably could get it, or somebody could get it as well. The tremor differentiation really lies in what plane the tremor becomes most prominent. Parkinson's, as I mentioned, resting tremor. So it's going to be where, again, it's like laying by your side, and it's, but when you lift up your hands, it may not be as obvious. Whereas essential tremor is the opposite. It doesn't really occur at rest. It's more of an action tremor. So when you hold things, you hold this coffee mug, and then the weight makes your hand kind of shake a little bit like that. There's different ways in which we test the tremor in clinic for us to be able to tell the difference. Sometimes it can be confusing. Sometimes they have mixed features. And that's where that scan I was talking about, that DAT scan can be really helpful.
Yeah. So sometimes we call essential tremor benign sometimes, probably just because it doesn't go along with these other things, but it can be problematic
Very
for
disabling,
people.
yeah.
What can we do for that type of tremor?
Different medications are available to treat that kind of a tremor. I will add that, we don't always have to treat that. Some people do, it's very mild, it doesn't really bother them, so we don't have to treat it.
Right.
Some people might get away with special tools, like weighted utensils, weighted cups and mugs, because that seems to help stabilize the movement a little bit and might get away with that.
Yeah.
But sometimes, yes, it does need treatment. There's different medications, not dopamine, that helps with those kinds of tremors. And then DBS is probably our most effective treatment for that.
Okay. Yeah. For a more severe.
Yeah, I tend to have
tremor.
a much lower threshold to go for DBS in essential tremor than I do in Parkinson's.
Okay. And highly effective in that disease as well, if you're a good candidate. Yeah,
very much so.
Great, and yeah, so not all tremor is Parkinson's, but doesn't mean there's not something that we can do about it medically.
Yeah,
either.
so not all tremor is Parkinson's. Not all Parkinson's will have tremor.
Yeah. Okay, great, good. The South Dakota Parkinson's Foundation provides services across South Dakota. The organization is committed to improving the quality of life for people affected by the disease. Executive Director Terrence Sietsma and Event Assistant Julie Egebraten-Nord spoke with Prairie Doc about the foundation.
South Dakota Parkinson's Foundation aids individuals with the disease and their support system. Whether it be caregivers, family, friends, or anyone involved with an individual affected, the foundation is there to aid with the journey.
So that means anyone from someone that's diagnosed with Parkinson's disease to their caregiver, family members, friends, anyone and everyone involved in their diagnosis. And we do that in a number of ways. The first one is information. So when someone is newly diagnosed by their doctor, we have newly diagnosed packets that we give out to those patients. And that has just a bunch of information and ways to connect them to different resources that they might need with their Parkinson's journey. We also give out medical alert bracelets and necklaces for free for anybody through some grant funding that we have. We connect people to support groups across the state of South Dakota, and the support group leaders are often persons that have Parkinson's disease or are caregivers or family members of someone that has Parkinson's disease. We also rely a lot on medical professionals across the state.
Fundraising supports their mission, where they award grants each year to those with Parkinson's.
A lot of people across the state have to travel 3 or 4 hours to see a neurologist because there's such a shortage. It could be for modifications to their homes, if they need a ramp, if they need to put up grab rails, anything like that. So that's what we do with the fundraising that we do across the state of South Dakota, is we try to give it back in grants for people because we just know that they're going through, a lot of people, it's difficult when you have a diagnosis and then when you add on adaptive equipment and things like that you might need. That's a huge barrier for people.
I just think education is just such a key part, We have a free conference coming up April 26th. And it's kind of like when people learn about us and they learn about tips about their own well-being and caregivers' well-being, and then they find out what resources we can help them with.
Great resource for our patients in South Dakota, and probably other states have similar organizations. What do you find, they talked a lot about caregiver support, so maybe you're meeting patients, maybe you're dealing with really challenging cases. How do you counsel those spouses, caretakers, children on how to best support their loved ones with this disease?
Yeah, it's a complicated disease with a lot of moving parts. I think that a very basic thing they can do to just help them support is to help navigate the medical system.
Yeah.
I think come with them to their appointments, know what their medications are. They'll be changing all the time, so they'll kind of want to help out with that. Organize the medications, making sure they're taking them at the right times, and then just keeping an open dialogue with your doctor as well, because I think it's often difficult for the patients to do it themselves.
Yeah.
So to have somebody who kind of advocates for you and does that, I think is a big one. Caregiver burden is a real thing, though. I think there can be kind of levels of burnout as well, but we do actually have in Sioux Falls a caregiver support group for Parkinson's as well. So lots of really good resources there too.
Yeah, great. And we've talked about, therapy, which is a more sort of specific and focused thing. Are there other just activities or things that you recommend people do at home that can help them in the long run with this disease?
So I like to tell people that it doesn't really matter to me what kind of exercise they do, but just that they do something.
Okay.
Exercise is actually the single most effective intervention for Parkinson's disease.
That's a big statement.
It is.
Yeah.
And there's no medication I can give you that is going to slow down the course of the disease. Exercise has disease modifying effect.
Okay.
So if there's anything that you can do to slow down the progress, that is it. We do know that aerobic or cardiac exercise is where the most of the benefit seems to lie.
Okay.
Whatever it is, whether you bike, walk, run, swim, rock steady boxing is a really popular thing that people do, and it's just one way to be physical.
Right.
People play pickleball, people do all sorts of things. So it doesn't matter to me what it is, just do a thing that you will be consistent and regular with, because that is more important than the actual intensity of the exercise.
Okay.
But something that gets your heart rate up, something that gets a little sweaty. That's really where the benefit seems to lie. And we kind of follow those AHA, American Heart Association guidelines of like 120 minutes per week is kind of where that magic number seems to lie. The more you do, the better. Okay. But something is better than nothing. So that would be one. It's one of the first things I talk about with patients. I like to make a point about that.
Yeah. Is it challenging sometimes for patients to find that thing that also they feel safe about doing? Patients who do have problems with balance and movement.
100%.
Yeah.
And I'll work with them to kind of figure out what's a good way to do it. The physical therapist is a great resource for that as well. I mean, even if you're just sitting there and you've got a little bike pedal while you're watching TV, I mean, that's going to help too. Better than nothing. But yeah, experiment. See what it is. The thing that you enjoy is the thing you're going to stick with the most. So there's, I would say that's the biggest one.
Okay. Yeah, great. You mentioned a little bit earlier when we were chatting about, DBS is probably the most common and well-known sort of surgical or interventional therapy, but there are others. So tell us what other procedural things can help with Parkinson's disease.
There is a procedure called focused ultrasound. Okay. People call that the laser surgery, because essentially what you're doing is using ultrasound waves to create a laser. And it's a completely non-invasive procedure. So there's no anesthesia, there's no cutting of the brain, there's no downtime. It's kind of less of an undertaking, kind of a one and done thing compared to something like DBS. Okay. We can do both sides. It kind of harks back to those lesional surgeries that I was talking about, where we were like poking holes in the brain. This is a lot more precise than that. Right. And yeah, we're kind of hitting those same targets and just intentionally causing damage to that part of the brain. Can be very effective. It seems to be the most effective for tremor. Okay. While DBS we can do both sides at the same time, this has to be staged about 9 months apart. Okay. And not everybody's going to be a candidate for this either. And one of the reasons why I don't recommend it as much is because longevity is not as established with that one. You can't keep poking holes in the brain, but I can up the stimulation on the DBS as the disease progresses. So there is that, but it certainly could be a good option for people. And that's a common one I get asked as well. Okay.
And that's something you would do one time and you wouldn't have the option to repeat if you had to. You can. Okay.
You can repeat it. It's just there's a limit to how much you can keep doing it.
Yeah. Okay.
And then there's two other that I will bring up that are technically surgeries, but not brain surgeries. So one of them is something called Duopa, which is a carbidopa-levodopa. That's a medication that's brought in a gel form. Okay. And that gel is sort of given through the small intestine. So we've created kind of like a little feeding tube on the other part of the stomach in the small intestine, and we're infusing the drug through it. Okay. So it bypasses the stomach, which gives us a lot more control over how the medication is absorbed, and you can kind of give it over a more sort of consistent period of the day. So instead of taking your medication I don't know, 6 to 8 times a day, you just have this gel running through. It is cumbersome because you've got to carry all this stuff around with you.
Okay.
So the other option, which actually technically is not a surgery, but it's another option that's a bit more sophisticated, is a levodopa pump. This one just came out in this past year. It's been approved in other international markets for a long time, but recently has come to the US. Not technically approved by Medicare yet. That is to be determined this year. Probably will be, but not currently available to everybody.
Got it.
But it's kind of like an insulin pump, if you've seen those, and it's just, instead of running insulin, it's running levodopa. And so a lot less, but you still got to kind of walk around with some stuff too, but another option.
Subcutaneous, under the skin kind of pump.
Like a little patch with a needle.
Yeah. And so with those, is it like insulin in that you might change the rate for different times of day and stuff like that?
We have some ability to program it. And you do have to switch it out. So there's that, but you have to do that maybe once a day as opposed to taking a pill multiple times a day.
Sounds nifty.
So it is, it can be. I think that's probably the most recent development that I'm excited about is this pump.
An option to not have all the pills, because it can be a lot. Just the volume of pills can be a lot too.
It takes over your life sometimes, you know?
Yeah. All right, cool. Another thing we really like to talk about on this show is what's out there that's misinformation about this disease that we're talking about. So, we live in an age where a lot of people are on social media, or the internet in general, and not everything is good information. So what unique to Parkinson's do you hear a lot from your patients that they read about online, but just simply is something that you have to kind of debunk in clinic with them?
So there's one that is not completely wrong, but it's the role of diet in Parkinson's disease. Obviously, if you eat a healthy diet, it's going to be good for you in many ways. I don't think it takes, a doctor to tell you that if you eat healthy, you'll feel better. But I think that there's an it's just put up more on a pedestal than I think it needs to be. People think that if they eat a certain type of way, that their Parkinson's will go away or reverse, and that's just simply not true. In the same way that exercise has a disease-modifying effect, diet does not. So it doesn't matter, how many vegetables you eat, it's not going to make a difference ultimately to the Parkinson's. So that's a tough one that I come across a lot, and it's not wrong to have agency over your disease, and I think that's really what people are kind of going for, but people are doing a lot of that, or supplements, kind of a sort of a similar thing to diet, that if you take the supplement, this will cure your Parkinson's. So that's a lot of what I see too.
Are there supplements that are marketed for Parkinson's? So So, but nothing that has good data behind it.
I think they're mostly safe. A lot of people ask me if they can take them along with their medication, and I usually say okay, because I don't think that they're going to hurt them. But if if they're going to ask me like, hey, is this going to make a difference? I'm going to say no. And they're not cheap. Some of them are not cheap.
I know.
And
so they're not harmful, but like, you're spending your
do you want to spend $80 a month on this thing that's going to do nothing? So that's kind of what I struggle with. But if that's what you want to do, and I don't think it's going to hurt you, I usually do give the okay for that. So that's kind of another one that I come across too. And then I get a lot of questions about stem cells.
What's the stem cell marketing about Parkinson's like? And I assume if they're asking about this, there are places that are providing this therapy. So what are they saying that they do, and what's the reality behind it?
So specifically, what these stem cell treatments are doing are taking something called mesenchymal stem cells. These are sort of undifferentiated cells that they'll take from fat or placental tissue, and they'll be like, these cells can become anything. These cells can become what we want them to become. And we'll put them in you, and then they'll become neurons. And then we will reverse your disease. And that's just not what it does.
Are there places that are actually like putting these in via spinal tap, or like how are they administering them? So
it's a cross between usually a combination or one of the other of an injection or intrathecal going into the spine. And I usually tell people that the best thing they can ever do is that they don't work. But there's other complications that can happen as a result,
Sure.
not to mention things like infections and weird growths and things like that can happen as a result. And some of them can be really, really predatory. I know somebody, this was a research that we had done where we found like what's the range of money that people have spent on this. And that's not including things like travel to different parts of the world. They exist in the US,
right?
But there's a lot of them in places like Mexico and China, and people will go there and spend that money.
Right.
And I've heard a range of like a couple of $1,000s to, I think the highest I'd ever heard was $80,000.
Oh, that just hurts to hear.
It really does.
Yeah.
And I really do feel like that they're preying on sort of the desperation of these patients to be like, there must be a cure out there and I want to be able to do it. And so that I actively sort of, advise against doing.
Yeah. And in the case of stem cells, it's probably not because of a lack of research. I mean, like, people have been researching stem cell therapies in a lot of ways, whereas some of these supplemental things, maybe it's not been studied and we don't have the data. But stem cells, like, you can definitively say this is not going to help your Parkinson's disease.
We don't have the technology or the know-how to get those cells to do what we want.
Yeah,
that's just the reality. So they're just kind of injecting them blindly and nothing happens.
Right.
Yeah.
Right. I think a little bit, I can think of some patients I have who have like the sleep disorder that tends to go along with Parkinson's disease. What do you usually recommend for that? Are there over-the-counter medicines that tend to help with those sleep problems?
Yeah, there's a range of sleep problems that you can have in Parkinson's. There is that dream enactment that I had mentioned, but it can even be as simple as like insomnia or sleep fragmentation, that they're falling asleep but they're waking up a lot for no reason. They don't have to go to the bathroom, nothing's happened, but they're just waking up frequently. Melatonin is sort of my go-to with over-the-counter. Actually, I have a lot of evidence in the dream enactment behaviors, but it can help with the other things as well, with insomnia and sleep fragmentation. And then there's prescription as well. But melatonin is a good place to start. Most people are probably taking too much melatonin. Like, people who don't have Parkinson's and sleep problems are probably taking too much melatonin. Most people don't need more than 0.5 to 1 milligrams if you're going to take it just to help you sleep every once in a while. People with Parkinson's, they need a lot more.
Yeah.
I usually start between 3 to 6, but I've done as much as 18 milligrams, but under supervision. So
yeah. Okay. I guess we're kind of in our last minute of the show. What are the main things that you want, or one lasting message for the audience about this disease? I guess I'm taking away, like, this is a very treatable disease. Like, you can make your symptoms better, but it may take seeing a specialist and doing it with some frequency to adjust things.
Right, absolutely. There's a thing that we say in Parkinson's is that you don't die of Parkinson's, but you die with it. It is a disease that you will have to learn to live with. It'll be with you for as long as you're alive. But there's absolutely ways to make your quality of life better, and exercise.
Exercise. That's the
biggest
great
one.
Prairie Doc way to finish that segment. Thank you. We will be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you to our guest, Dr. Rai, for volunteering her time to help us learn more about Parkinson's disease. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
That dull ache or sharp shooting pain in your back can significantly impact your daily life. Back pain is the second most common reason people visit their healthcare providers. What's causing the pain in my back? Next time, On Call with the Prairie Doc.
My name is Carter Home, and I serve on the board of directors of the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,